Good morning, my dear students. This class is about diuretics. Abnormalities in fluid volume and electrolyte composition are common and important clinical problems, and that can be life threatening too. So, drugs that block the transport functions of the renal tubules are widely used in treatment of these disorders. So, although various agents that increase urine flow have been described since antiquity, but it was not until 1957 with the synthesis of chlorothiazide that a practical and a powerful diuretic agent became available for widespread use. So only after 1937 we started using diuretics. Technically, the term diuresis signifies an increase in urine volume, while natriuresis denotes an increase in renal sodium excretion. Because the important natriuretic drugs almost always also increase water excretion, say they are called as diuretics, and the increase in sodium excretion is assumed. So here the competency is the student should be able to describe the mechanism of action, types, doses, side effects, indications and contraindications of diuretics, and it comes in pharmacology competency 1.24. So as we know these are the agents which are used to increase the production of urine and the increased excretion of sodium along with sodium excretion, it is known as natriuresis. Along with this, water also gets excreted, and that's how they cause diuresis. Now the question arises, why diuresis, where it is required? So failure to excrete excess fluid from the body, for example in case of renal edema, congestive heart failure or metabolic disorder, or to get rid of body's excess salt, and also reduce blood pressure in case of hypertension, because as we know sodium it causes vasoconstriction and rise in blood pressure, retention of water, extracellular fluid volume, and the loss of sodium and chloride and water helps in reducing extracellular fluid and lowering bp. So some of the common conditions wherein we use diuretics are primary or essential hypertension, and as we know these drugs they increase excretion of sodium and water, so naturally they should reduce edema. So it could be in case of pulmonary edema or systemic edema, and electrolyte imbalances, and also as adjuncts in case of glaucoma. So accelerate the urine formation and removal of sodium and water. So apart from this, so here you can see without diuretics, urine formation, with diuretics, how it occurs, and reabsorption, secretion, filtration. These are the mechanism by which urine is formed. And now coming to urine, it is composed of water, electrolytes, and waste products from blood. So it contains ammonia, sulfate, phosphate, chloride, magnesium, calcium, potassium, sodium, creatinine, uric acid, urea. But 95% of this it contains water. So now all of as we know urine formation, how does it occur? It occurs by filtration, tubular reabsorption, tubular secretion, and finally excretion occurs. So urine formation, as it occurs, a structural and functional unit of kidney is nephron, and it has proximal convoluted tubule, Bowman's capsule PCT, then loop of Henle descending, then thin ascending, thick ascending, then distal convoluted tubule and collecting duct. Now coming to form proximal tubule, sodium bicarbonate, sodium chloride, glucose, amino acids and other organic solutes are transported reabsorbed. How these are reabsorbed by specific transport system in early proximal tubule. So, along with sodium, water is reabsorbed passively. So, it has to maintain constant osmolality of proximal tubular fluid. So, as tubule fluid is processed along the length of proximal tubule, the luminal concentration of the solutes decrease relatively to the concentration of inulin, which is an experimental marker. So, that is neither secreted nor absorbed by renal tubules. So, inulin concentration itself rises owing to water reabsorption by the proximal tubule. Of the various solutes reabsorbed in the proximal tubule, most relevant to diuretic action are sodium bicarbonate and sodium chloride. So, though various solutes are absorbed, so in case of diuretics, we are related to sodium bicarbonate and sodium chloride. So, now currently available diuretic agents, so carbonic anhydrase inhibitor acetazolamide, it acts in proximal tubule, so which acts by blocking sodium bicarbonate reabsorption. So 20 to 25% of sodium reabsorption occurs in luminal loop of Venn, and 5 to 10% in distal tubule, 3% in collecting duct. If it is not absorbed, then it is excreted through urine. So, sodium bicarbonate reabsorption by the proximal tubule is initiated by the action of sodium and hydrogen exchanger located in the apical luminal membrane of proximal tubular epithelial cells. Now, this transport system allows sodium to enter the cell from the tubular lumen in one of the exchange with the proton from inside the cell. As all the portions of nephron, sodium, potassium, ATPs in the basolateral membrane pump the reabsorbed sodium out of the cell into the interstitium and keeps the intracellular concentration of sodium low. So, this sodium potassium ATPs is important. So now, hydrogen which is secreted into the lumen, it combines with bicarbonate to form carbonic acid. So carbonic acid, like bicarbonate, is not directly transported by proximal tubule cells. Instead, carbonic acid is dehydrated into carbon dioxide and water, which readily move across the membrane. So this dehydration requires of enzyme, which is provided by carbonic anhydrase. So this process are important because accordingly the diuretic agents are classified. So carbonic anhydrase, if you prevent this, then dehydration can be prevented and you prevent bicarbonate reabsorption. Carbon dioxide produced by dehydration of carbonic acid enters the proximal tubule cell by simple diffusion. Then again it is rehydrated back to carbonic acid. After dissociation, hydrogen is again available for transport by the sodium hydrogen exchanger, and the bicarbonate is transported across the basolateral membrane and to maintain it is available. Thus, bicarbonate reabsorption by the proximal tubule is important and depends on carbonic anhydrase activity. So, carbonic anhydrase is inhibited by carbonic anhydrase inhibitor acetazolamide. So, now we have learned proximal convoluted tubule. Your carbonic anhydrase enzyme is necessary for catalysis of certain reactions. If you inhibit that enzyme, you can prevent reabsorption of sodium. In the late proximal tubule, as bicarbonate and organic solutes are largely removed from the tubular fluid, the residual tubular fluid closely resembles a simple sodium chloride solution. Under these conditions, sodium reabsorption continues, but the protons secreted by sodium hydrogen exchanger is not treated by bicarbonate. So this of the reactions occurs in proximal tubule. Now, loop of Henle, the thin loop of Henle does not participate in active salt reabsorption. Thin descending loop of Henle, it does not participate in active salt transportation, but it helps in water reabsorption. So water is reabsorbed from thin ascending loop of inlet by osmotic forces generated by hypertonic medullary interstitium. As in the proximal tubule, solutes like mannitol or glucose in the lumen will oppose water extraction and increase the delivery of water to most distal sites. So osmotic diuretics, they act at various levels. They prevent water reabsorption, and that's how they dilute urine. Now the thick ascending loop of Henle relatively reabsorb sodium chloride from the lumen, about 33% of the filtered sodium, but unlike proximal tubule and thin limb, it is extremely impermeable to water. So thin limb it is permeable to water, but thick limb it is extremely impermeable to water. Salt absorption in the thick ascending limb therefore dilutes the tubular fluid, leading to diluting segment. So, the sodium chloride transport system in the lumen membrane of the thick ascending limb is a sodium potassium 2 chloride transporter. So, this is important because about 25% of sodium which is ejected from proximal convoluted tubule, it gets reabsorbed at this site, and drugs diuretics which act at this site are called as highly efficacious diuretics. Loop diuretics are highly efficacious, and these drugs they act by inhibiting sodium potassium 2 chloride transport. So this transport is selectively blocked by loop diuretics. So although the sodium potassium 2 chloride transporter is itself electrically neutral, the action of the transporter leads to excess of potassium accumulates within the cell. So, since the sodium potassium ATPase is also pumping potassium into the cell, this results in the back diffusion of potassium into the tubular lumen, and which creates positive electrical potential in the lumen. Now, this electrical potential provides the driving force for reabsorption of magnesium and calcium via the paracellular pathway. Thus, inhibition of salt transportation in thick ascending limb by loop diuretics cause an increase in excretion of magnesium and calcium also. Now coming to distal convoluted tubule. So here the sodium chloride reabsorption is less, only about 10% of filtered sodium than in the thick ascending limb. So, like in thick ascending limb, this segment is relatively impermeable to water, and the sodium chloride reabsorption therefore dilutes the tubular fluid. The mechanism of sodium chloride transport in the distal convoluted tubule is electrically neutral. Sodium and chloride transport, which is pharmacologically distinct from sodium potassium 2 chloride transporter in the thick ascending loop of Henle. This transport, that is sodium chloride transport, is blocked by thiazide diuretics because these are the agents. Thiazide diuretics, they act at this site, distal convoluted tubule. So, because the potassium does not recycle across the apical membrane of the distal convoluted tubule as it does in the loop of Henle, there is no lumen positive potential in this segment, and calcium and magnesium are not driven out of the tubular lumen by the electrical forces. So, thiazide diuretics, they do not have action on these ions. However, calcium is actually reabsorbed by distal convoluted tubule via the apical calcium channel and also by basolateral sodium calcium exchanger. So this is regulated by parathyroid hormone. Now coming to next segment, collecting tubule. So this is responsible for only 2 to 5% of sodium chloride reabsorption. So, despite this small contribution, though it looks like small contribution, the collecting tubule it plays a vital role in renal physiology and in diuretic action because the final site of sodium chloride reabsorption occurs in collecting tubule, which is responsible for the determination of final concentration of the urine. So, collecting tubule and late distal tubule is the site where mineralocorticoid exert a significant influence. So collecting tubule here mineralocorticoid plays a major role. The collecting tubule is the major site of potassium secretion by the kidney and thus it is the site at which all diuretic induced changes in potassium metabolism occur. So, the mechanism of sodium chloride reabsorption in collecting tubule is distinct from the mechanism of other segments. So, principal cells are the major sites of sodium, potassium, and water transport, and the intercalated cells are the primary sites of protein secretion. Unlike the epithelial cells in the previous segments, the apical membrane of the collecting tubule principal cells does not contain co-transport system for sodium and other ions. So these membranes exhibit separate ion channels for sodium and potassium. Since these channels exclude anions, transport of sodium and potassium leads to massive net movement of charges across the membrane. So this is regarding collecting that. So this driving force because the driving force of sodium entry into the principal cells greatly exceeds that of potassium exit, sodium reabsorption predominates and significant lumen negative electrical potential develops. So the sodium enters the principal cells by this mechanism and channel is then transported into the blood via the basolateral sodium potassium ATPase as in other nephron segments. So the lumen negative electrical potential drives the transport of chloride back to the back to blood and via the paracellular pathway and also drives potassium out of the cell through apical membrane. Thus, there is an important relation between sodium delivery to the collecting tubule and the resulting secretion of potassium. So, diuretics that act the collecting tubule will increase sodium delivery into this site and will enhance potassium secretion. So, if sodium is delivered with an anions such as bicarbonate which cannot be reabsorbed uh, as readily as chloride, the lumen negative potential is increased and potassium secretion will even further enhance. This is the basis for most diuretic induced potassium wasting. This you should understand because most of them they cause hypokalemia and this is the basis for hypokalemia, especially when concomitant volume depletion has caused enhanced aldosterone secretion. So, reabsorption of sodium and its coupled secretion of potassium is regulated by aldosterone and its action is on transcription. Gene transcription increases the activity of both apical membrane channels and the basolateral sodium potassium ATPase, which leads to an increase in transepithelial electrical potential and which further increase in sodium reabsorption and potassium secretion. And in the absence of antidiuretic hormone, the collecting tubule is impermeable to water, and dilute urine is produced. So this is only site in the nephron at which membrane water permeability can be regulated. So ADH causes intracellular vesicles containing preformed water channels to fuse with the apical membrane of the principal cells, and thus increases the membrane permeability to water. So again, ADH secretion is regulated by serum osmolality and also by volume status. Thus, the ADH antagonists would theoretically be very useful drugs for inducing water diuresis, but such agents are not available. So now we have learned the physiology of urine formation. So now let us revise. So filtration. So as we know, it occurs by filtration, reabsorption, then secretion. Filtration, blood courses through the glomeruli, and which contains useful chemicals and also dissolved waste materials, and it soaks out of blood through membrane by osmosis and diffusion, and which produces filtered and flows through Bowman's capsule to form glomerular filtrate. So this contains glomerular filtrate. It contains water, waste products, sodium, potassium, glucose, and other chemicals that have been filtered out of blood. See, efferent arteriole, capillaries, capsule. So this filtration occurs like this. Blood is forced through a membrane. Only tiny particles pass through. It is like a sieve, protein and cells. Here you can make out how filtration occurs. Now, total rate of the filtration of the glomerulus, it is normal rate is 125 ml per minute, and per hour it is about 7,500 ml, and it comes to around 180 liters per day. Do we excrete 180 liters? No. Why? What is the reason? So this is because of reabsorption, that is movement of substances out of renal tubules back into the blood. Reabsorption back into our body, back into blood capillaries located around the tubules, and through reabsorption, water, sodium, glucose, chloride, and nutrients are reabsorbed. So reabsorption of sodium, this is pumped out. Sodium is pumped against gradient, and water diffuses down the gradient. Blue color is water and this is sodium. So reabsorption of sodium and water, along with sodium, water is also reabsorbed. Sodium is pumped against the concentration gradient from inside to outside the tubule, and water also crosses tubular membrane into blood outside the tubule by diffusion down the gradient. So reabsorption, it begins in proximal convoluted tubule, then continues in loop of Henle, distal convoluted tubule, and collecting duct. So now 99% of 180 liters of glomerular filtrate, it returns to blood through passive reabsorption, and glucose is completely reabsorbed, actually transported out of tubules into the peritubular capillaries, but sodium is partially reabsorbed and it goes to remaining segments. The amount of sodium reabsorption depends largely on how much salt we consume. So increase intake, it decreases sodium reabsorption in blood. Now the mechanism, now the last mechanism is secretion. So secretion is a reabsorption in reverse. So in case of reabsorption, substance from tubules to blood, whereas secretion, it is excreted out substance from the blood to tubular fluid. So how secretion occurs? It is by an active transport or by diffusion. And why it is necessary? It helps to maintain acid base balance in our body. So penicillin, aspirin, potassium, hydrogen ions are secreted in penicillin. Principles of chemotherapy or learned how penicillin is secreted. So these are secreted into distal convoluted tubule and collecting duct. So secretion from blood to tubule. So from here to blood is reabsorption. See here. So peritubular capillary, distal convoluted tubule, then ascending loop, collecting duct. So reabsorption from the tubular fluid into blood and secretion from blood to tubular fluid. Now, what are the some conditions for diuretic use? So, edema in case of congestive heart failure because the failure of heart decrease cardiac output as a compensatory mechanism. Sympathetic system gets activated, which in turn activates renin-angiotensin system and aldosterone secretion, sodium retention. Along with sodium, water is also retained, and edema occurs, increase in extracellular fluid. So, in order to reduce this edema in case of congestive heart failure, which causes diuresis and excretion of excess fluid, even in case of acute pulmonary edema to relieve congestion in lungs, liver disease, and nephrotic syndrome, hypertension, reduction in sodium, it reduces blood pressure and conditions that cause hyperkalemia. You can see edema in case of congestive heart failure, pulmonary edema, liver disease. Now, what is the reason for edema in case of liver disease, ascites? So, because of reduced plasma protein results in less oncotic fluid in liver disorder in vascular system, and fluid loss occurs at capillary. And also because of obstructed blood flow through the portal system, and finally due to increased pressure from congested hepatic vessels. So, nephrotic syndrome, renal disease, and hypertension. Now, what are the types of diuretics that are available? So, you've learned the various segments of nephron. So, these are the targets for diuretic agents. So, here we have proximal convoluted tubule, ascending loop, distal convoluted tubule, cortical collecting duct. So, in case of proximal convoluted tubule, sodium transporter is by sodium hydrogen transporter. So, here carbonic anhydrase catalyzes this reaction. If you block this, then you can prevent reabsorption of sodium. So, here the agents we have are carbonic anhydrase inhibitors. So, in case of ascending loop of Venn, thick ascending loop, 25% of sodium gets reabsorbed, that is by sodium potassium chloride co-transporter. Here we have loop diuretics. Then distal convoluted tubule, sodium chloride transporter. So thiazide diuretics act at this level. So in case of cortical collecting tubule, so sodium channels, aldosterone plays role here. So potassium sparing diuretics act at this level. Then osmotic diuretics, they act at various levels. So carbonic anhydrase inhibitors, proximal convoluted tubule, acetazolamide is the prototype. Now mannitol, it is an osmotic diuretic. So it acts at descending loop of Henle, PCT, then ascending loop, and thick ascending loop diuretics. These are called as highly efficacious diuretic agents. Then distal convoluted tubule, which act by blocking sodium chloride transporter, thiazide diuretics, then collecting duct, aldosterone antagonists. So, carbonic anhydrase inhibitors, osmotic diuretics, then loop diuretics, thiazide diuretics, and aldosterone antagonists. So to repeat, we have carbonic anhydrase inhibitors, osmotic diuretics, loop diuretics, thiazide diuretics, and aldosterone antagonists. So these are the various drugs that are available classification. So with individual group, you should know what is their mechanism of action, therapeutic uses, adverse effects, indications, and contraindications. So first group is carbonic anhydrase inhibitors. So these are classified again as highly efficacious, moderate, and less efficacious drugs. So loop diuretics, they are highly efficacious like that. Again, depending on their efficacy, they can be classified. Now coming to first group, carbonic anhydrase inhibitors. So carbonic anhydrase is present in many nephron sites, including the luminal and basolateral membrane, the cytoplasm of the epithelial cells, and the red blood cells in the renal circulation. But the predominant location of this enzyme is in the luminal membrane of the proximal tubule. So there it is necessary to catalyze the dehydration of bicarbonic acid, which is a critical step in the proximal reabsorption of bicarbonate. So inhibition of carbonic anhydrase, it blocks sodium bicarbonate reabsorption, causing sodium bicarbonate diuresis and a reduction in total body bicarbonate stores. So the carbonic anhydrase inhibitors were the forerunners of modern diuretics. They are derived from sulfonamide, and hence with patients who are allergic to sulfonamide should not be administered. The structure of acetazolamide, here that we have acetazolamide. The structure of acetazolamide, it contains sulfonamide group, which is essential for activity, and substitution at this point completely block the effects of carbonic anhydrase. So carbonic anhydrase, it is present in proximal convoluted tubule. It reacts with carbon dioxide and water, and the negative bicarbonate ion moves out of the renal tubule into blood in a nearby capillary. But and hydrogen ion moves out of the tubule into the filtrate, and it gets exchanged with sodium and moves back inside the tubule. So they prevent formation of bicarbonate and hydrogen, retention of water in urine, and bicarbonate diuresis occurs. See carbonic anhydrase enzyme. It is present in proximal tubular cell basolateral membrane, and how it works here you can make out. So sodium uh, is carbon dioxide and water. Carbonic acid is formed, again bicarbonate and hydrogen. So this hydrogen is exchanged with sodium. Hydrogen combines with bicarbonate to form carbonic acid and carbon dioxide and water. So this is absorbed like this, again by carbonic acid and bicarbonate and hydrogen. So sodium and hydrogen exchange occurs like this. Okay, sodium and bicarbonate. So this is the mechanism by which carbonic anhydrase inhibitors act. So acetazolamide, diazolamide are the compounds, all are sulfonamide derivatives. So as I told, they act by inhibiting membrane-bound carbonic anhydrase in the cells of proximal tubule, which leads to blockade of this reaction. Carbonic anhydrase cannot be converted to water and carbon dioxide, which occurs in the proximal tubular lumen. So they cause acidosis, azolamide, you can acidosis like this, you can remember. So acetazolamide, it causes acidosis. So now you learned carbonic anhydrase inhibitors which are present with these drugs. They act at proximal convoluted tubule. Now, all the carbonic anhydrase inhibitors are well absorbed after oral administration. An increase in urine pH from the bicarbonate diuresis is occurs. It occurs. Increase in pH occurs within 30 minutes, and it is maximum at 2 hours, and it persists for 12 hours after a single dose. And excretion occurs by tubular secretion in proximal tubule, and dosing inhibition of sorry. So you learned carbonic anhydrase inhibitors increase in urinary pH from bicarbonate diuresis occurs within 30 minutes after its absorption and maximum at 2 hours, and this action persists for 12 hours after a single dose, and it gets secreted in tubules, and that's how it gets excreted. So now we have learnt pharmacokinetics and pharmacodynamics. Pharmacodynamics is by preventing carbonic anhydrase activity which depress bicarbonate reabsorption in proximal tubule. Now it is given orally, and the azolamide topical eye drops are also available. And adverse effects, these are some of the adverse effects it causes: hyperchloremic metabolic acidosis. Acidosis results from chronic reduction of body bicarbonate stores by carbonic anhydrase inhibitors. So, bicarbonate wasting limits the diuretic efficacy of these drugs to 2 to 3 days. Renal stones, phosphates, and hypercalciuria occur during the bicarbonate response to carbonic anhydrase inhibitor. Renal excretion of uh, citrate may also decline with chronic use. Calcium salts are relatively insoluble in alkaline pH, which means that the potential for renal stone formation from these salts is this salt is more. Okay, that's how it causes precipitation of calcium phosphate in alkaline urine, which is responsible for nephrolithiasis. Then potassium loss. Potassium wasting occur because sodium bicarbonate present to collecting tubule causes an increase in the lumen negative electrical potential in that segment, which causes potassium excretion. So this can be prevented by simultaneous administration of potassium chloride. And it also causes drowsiness, paresthesias with large doses. These agents accumulate in patients with renal failure, and CNS toxicity can be marked in such individuals. And they are also capable of causing hypersensitivity reactions like fever, rashes, bone marrow suppression, then interstitial nephritis. So, contraindications: carbonic anhydrase inhibitors should be avoided in hepatic cirrhosis. Alkalization of the urine will decrease urinary trapping and thus excretion of ammonium, and may contribute to development of hepatic encephalopathy. So, citazolamide, it is available 250 mg is the strength. Now, coming to therapeutic uses, these are used as adjuncts in long-term treatment of open-angle glaucoma. Inhibition of carbonic anhydrase enzyme decreases the rate of aqueous humor formation, thus it reduces intraocular pressure. So this effect is effective both in acute and chronic management of glaucoma, and making it the most common indication for the use of carbonic anhydrase inhibitors. Topically active carbonic anhydrase inhibitors for use in glaucoma, topically also these are used. And before ocular surgery, along with the myotics in certain cases. Then metabolic alkalosis. In most cases, to maintain it is a consequence of decreased total body potassium and intravascular volume or of high level of mineralocorticoids. Hence, it is administered to correct these underlying conditions. However, when alkalosis is due to excess use of diuretics in patients with severe heart failure or saline administration, it is contraindicated. So, because of elevated cardiac filling, in such condition, it should not be useful. In these cases, it's also used in case of acute mountain sickness, weakness, dizziness, insomnia, headache, nausea occur in case of mountain travelers. So who rapidly ascend above 3000 and the symptoms are usually mild and last for a few days. In more serious cases, rapidly progressing pulmonary and cerebral edema can be life threatening. So, yeah, by decreasing cerebral fluid CSF formation, by decreasing pH of the CSF and brain, acetazolamide can enhance performance status and diminish symptoms of mountain sickness. Prophylaxis can also be achieved by starting oral acetazolamide 24 hours before ascent. So these are also used in case as adjuvants for the treatment of epilepsy and in case of hypokalemic periodic paralysis and to increase urinary phosphate excretion, hypophosphatemia. So in case of metabolic acidosis, it is as a consequence of decreased total body potassium and intravascular volume or of high level of mineralocorticoids. So it is treated by excretion of these underlying, it is treated by correction of these underlying conditions and not with acetazolamide. So in case of metabolic acidosis due to decreased total potassium and decreased volume or high level of mineralocorticoids, here the condition should be treated not with acetazolamide. But in case of alkalosis due to excess use of diuretic in patient with severe heart failure, saline administration may be contraindicated because of elevated cardiac failure. So in these cases, acetazolamide can be useful.